Welcome back. This time in section 39 of the online anatomy review, we're going to be discussing the neck. Here we can see a little bit of imaging, and it's always good to remind yourself in cross-sectional images how this imaging will project with what you're thinking about soft tissues. Here you can see that there is a few structures that you want to know. You can see the angle of the mandible on both the left and the right side, overlaying one another just slightly. You can also see the body of the hyoid bone and a lucency of the pharyngeal and laryngeal apparatus in behind that, with the greater horn posteriorly and a lesser horn more anteriorly. Then you can see the arches of C1, the anterior and a posterior arch, with the dens protruding up from C2. In the neck, with the superficial veins, you can typically remember them by remembering that they look like an N and a mirror image of an N. The N draws up from the external jugular, where it will cross from the lateral side to the medial side of the sternocleidomastoid. Then it will communicate down to the anterior via the communicating branch. There's your N. If you draw a mirror across the midline, you would have the reverse of that on the opposite side. At the top of the N you have a Y, which would be the retromandibular vein, and coming forward from that, the facial vein. The facial vein will be found at the notch just by the body of the mandible, and it will carry up onto the face. Deeper yet, we have the internal jugular, and the internal jugular will sit encased within the carotid sheath. Along the outside edge of that carotid sheath you have the ansa cervicalis, and then medial to that you're going to have the two components of it, which will be the descending limb and the cervical limb. Then there's going to be the carotid, the common carotid, which will then bifurcate at the level of the hyoid into an internal and external carotid. So we have the facial vein, which will begin at the angle of the eye as the angular vein, and that will descend down towards the mandible. It will join anterior divisions of the retromandibular vein to form a common facial, which will then dump into the internal jugular. The retromandibular vein is found within the substance of the parotid gland and will join with the superficial temporal and maxillary veins. Then it will split into a couple segments which will join with either the facial or with the posterior auricular, and then they'll come and drain into the external jugular. External jugular will be formed by the union of the posterior auricular veins and the retromandibular veins. Now there's going to be a lot of investing cervical fascias that are cylindrical fascias covering over the neck. The superficial investing fascia is going to go up onto the face and is known as the SMAS, or the superficial masseteric aponeurotic sheet. This SMAS, which is an investment of the cervical fascia, can actually be used in reconstructive surgery and facial suspension surgeries as an anchoring point, as well as a tension reduction system to stop the uneven tension on portions of the face by distributing it through this SMAS. There'll be pretracheal and carotid, buccopharyngeal, and pharyngobasilar fascias. The buccopharyngeal fascia is important because there can be infections that will travel down this fascia because it will have a connection down towards the pericardium, and the pericardium can get infected, giving you a pericarditis. One of the things you should suspect when somebody has a pericarditis is that they maybe have had dental work within several months, because it can take months for this kind of infection to travel down from an infected dental needle or something of that manner. A few clinically relevant pearls that you can take for the board preparation would be the external jugular cannulation and the ultrasound that will show the placement of those cannulas and how to avoid the carotid. These can be cannulated in somebody fairly quickly since the vein is normally distended anyways and is more prominent by increasing intrathoracic pressure if you just ask the patient to hold their breath. If the vein is lacerated, the fascial attachments will prevent its collapse, and air emboli can be sucked into the vein, which can be very dangerous. So you have to be careful with this kind of thing, and we've discussed this very issue prior in the upper limb. Internal jugular vein can be catheterized by needle, and that will be inserted into the interval between the clavicle and the heads of the sternocleidomastoid for a central line approach. And the deep cervical lymph nodes are also going to adhere to the internal jugular vein in some cases of inflammation or malignancy, and that can cause the vein to tear during surgical removal of the nodes. If that occurs, the vein can be removed during a block, and the dissection of the neck can occur if there is tearing. The fascias of the neck are reminded to you here, and that there's an investing fascia that encases the trapezius and the sternocleidomastoid. And I wanted to draw your attention to the fascias around the back of the viscera, such as the trachea. That's going to be the buccopharyngeal fascia, and then the carotid sheath. There'll be an alar fascia between those, and this is where it can track down and cause a pericarditis. Remember, in the carotid sheath, we have the vein laterally, the artery medially, and the vagus nerve between the two. I'm going to leave this slide for you to look at. It's really just putting into words some of the pharyngeal fascias that we just discussed, and it talks about that danger space behind the buccopharyngeal fascia as well. There is the potential, however, of a retropharyngeal abscess, which can arise from the pharynx around the vertebral bodies. And this can happen from infected deep cervical lymph nodes that become abscessed. If these things become too abscessed, it can inhibit or cause problems with swallowing, or dysphagia can result. And what's going to happen is that the pharyngeal cavity will oftentimes cause an aspiration pneumonia if it ruptures. Let's move on to the thyroid and parathyroids. The thyroids are going to be composed of the right and left lobes, and they cross and connect at the isthmus at the second and third tracheal rings. They can have a pyramidal lobe, which is an embryonic remnant from its descent at the base of the tongue. And this can be vascularized fairly well. As far as the supply to the thyroid artery gland itself, there's going to be an inferior and superior thyroid artery, which will be drained by a superior, middle, and inferior thyroid vein. The superior thyroid artery is accompanied by the external laryngeal nerve, and the inferior thyroid artery crosses over the recurrent laryngeal nerve. Those are two important relationships that need to be respected in any neck dissections that you might read about or be keyed into on USMLE questions. As far as the parathyroids, they have some unique features that we'll talk a little bit more about in the developmental component of the head and neck section, but there's usually not associated entirely with the thyroid gland, but they will oftentimes be located around the superior and inferior poles of the thyroid. It's the inferior parathyroid which descends during migration of with the thymus, and it's oftentimes located in the inferior neck, or all the way down to the superior mediastinum potentially. In surgical removal of the parathyroids, they can be very difficult to find, but you can typically will find them by following the inferior thyroid artery. Total removal of the parathyroids, which secrete parathyroid hormone for calcium metabolism, will reduce plasma calcium and have a potentially fatal tetany effect. Here you can see the thyroid gland with its vascular supply and its venous drainage. You can have the pyramidal lobe that you can see as well, crossed with the isthmus, which will connect the two lobes. Here's an image that could be used in a clinical scenario. You can see here that there's a swelling on the posterior third of the tongue, and this is indicative of the same kind of imaging that you could see on CT scan, which would show a large tumor-like structure on the posterior third. Well, it turns out that what this is a piece of lingual thyroid. This is a remnant from the descent that occurred early in embryogenesis. And as long as you're looking at thyroid tissue of the tongue, you can have the thyroid tissue anywhere from that posterior aspect of the tongue all the way along the thyroglossal duct pathway. If it moves during swallowing, that's a key red flag issue to tell that it is a thyroid tissue. Cysts can be formed along the entire path of the migration of that thyroid tissue all the way down into the neck. The problem with cysts is that they may be remnants of thyroid that are fully functional, but there's no drainage path for them. They'll typically become apparent by the age of 5 as a midline swelling that will move with the thyroid during swallowing. That's a red flag issue in any of the STEM questions that you see in the USMLE. They can get infected and cause these infections that will need to be removed surgically. If there's any ectopic thyroid tissue, it can also be present along the path, and in rare cases it may need removed because of the infection. The lingual thyroid tissue is common but usually asymptomatic. There will be times when a thyroidectomy is called for. One of the risks of that is that the external laryngeal nerve, which is a branch of the superior laryngeal and is sometimes called the high note nerve, is vulnerable to damage as the thyroid is removed. The damage will affect the cricothyroid muscle sitting on the external surface of the larynx, but affecting the vocal cords. And by not being able to tilt the muscle and the vocal cords by lengthening them, it will cause the loss of the high notes and hoarseness and weakness of the muscles, which will get easily fatigued. Goiters are another commonly tested item, and you should be aware of how goiters and the tumors or thyroidectomy may have damage to not just the external branch, but also the inferior laryngeal or recurrent branch. They're vulnerable because of its intimate relationship with the inferior thyroid artery. And that inferior thyroid artery has the recurrent laryngeal nerve going right over top of it as it tries to get into the larynx. By damaging the recurrent laryngeal, there will only be one muscle that you do have functioning, which is that one that's supplied by the external laryngeal branch. All the rest would be paralyzed, and you would then see that there would be a loose vocal cord. Let's try another question. While examining a patient after an automobile accident, you find that a piece of glass has caused a wound in the superior aspect of the right occipital triangle of the neck. If there is damage, which movement would be the one that the patient would have lost? This is a fairly straightforward question for most of you at this point in your studies, but you have to know where the triangle is, and then you have to know what nerve runs through there. Well, the posterior triangles of the neck contain the occipital triangle, and running through that portion above the mid-belly of the sternocleidomastoid is the accessory spinal nerve, which is at risk of injury. Abducting of the arm to 90 degrees would be the deltoid by the axillary nerve. Abducting and protracting the scapula would be involved with pectoralis major or minor. And then we have the lateral rotation of the arm, which is through the suprascapular nerve, and flexing of the arm would be musculocutaneous. Then we'll look at the triangles of the neck. A lot of people have trouble with the triangles of the neck because there's a lot of borders and a lot of muscles to remember. I like to think that if you can draw a rectangle with a hypotenuse across it, you can do the triangles of the neck. There's 2 bones, 2 muscles, a midline, and 2 muscles with 2 bellies to remember. The 2 bones we'll put in first, which would be the mandible and the clavicle. Then we'll put a posterior muscle as the back border, which would be the trapezius. We'll throw in a midline, and now we need to add a couple more structures to it. One is the hypotenuse, which is the second muscle running across and now dividing it into 2 triangles. The front one would be the anterior triangle bordered by the mandible, the sternocleidomastoid, and the midline, and the posterior triangle would be bordered by sternocleidomastoid, trapezius, and clavicle. Now if we throw a hyoid in and two muscles with two bellies, we can finish the triangles of the neck. The first would be from the shoulder to the hyoid, which is omohyoid, and then the second muscle with two bellies would be the digastric, which has a posterior digastric innervated by cranial nerve 7 and an anterior digastric innervated by cranial nerve V3. Here you can see the two posterior triangles, the occipital and the supraclavicular, which is better known as the omoclavicular, which is also known as the subclavian, depending on whether you're interested in what's inside of it or where it's located. Let's look at the subtriangles of the anterior triangle of the neck. There are 4 of them, and remember the anterior triangle is bordered by the midline, the sternocleidomastoid, and the mandible. And then we can see the omohyoid and the anterior and posterior bellies of digastric, and now we have 4 subtriangles. They're named by 2 by location and 2 by what's in them. There's the submandibular under the mandible, and the submental, which some people will connect to the opposite side. Then we have the carotid triangle, because that's the one where the carotid artery will bifurcate at the base of the hyoid. And then finally the muscular triangle. Here's a clinical scenario that you'll sometimes see tested, and that would be the torticollis, which is wry neck. And this is a issue that occurs usually during an injury at birth, where the sternocleidomastoid will have a contracture in it, and this will be spasmodic, or it can be psychogenic. You can have a subclavian aneurysm, which involves the third part of the subclavian, which can compress the lower trunks of the brachial plexus. And this can be ligated without too bad of effect because of the anastomosis around the shoulder between the subclavian and the axillary arteries. The spinal accessory, when it's damaged, as you can see in this picture with the man's back to us, you'll get a shoulder sag and an inability to lift the shoulder above the horizontal plane. So let's look at the triangles in this diagram. Here you can see the anterior digastric and the posterior digastric with the submental and the submandibular triangles, and then the muscular triangle, which will have the 4 strap muscles or infrahyoid muscles associated. There are 2 strap muscles that are long, one which runs from the shoulder to the hyoid, omohyoid, and one which runs from the sternum to the hyoid, sternohyoid. Deep to those, the distance of the sternohyoid is split by 2 muscles, from the bottom of the sternum to the thyroid, which is the sternothyroid muscle, and then from the thyroid to the hyoid, which is the thyrohyoid muscle. There's not much need to memorize those names as long as you can remember that the muscles come and are named of what they attach to, and then they are named from bottom to top, always going towards the hyoid. In this image of the posterior triangle of the neck, you can see the 2 triangles divided up with an anterior triangle and a posterior triangle, and it talks about the different subtriangles of each of those areas. Here, there's a summary of what is in each of those triangles. In the occipital triangle, you're interested in the spinal accessory nerve and the roots and trunks of the brachial plexus, and that will be coming out of the scalene gap. In the omoclavicular triangle, also known as the subclavian triangle, you have the subclavian artery, which is an important structure, and then the branches coming from the remaining portions of the cervical plexus that are going to come over top of the clavicle. You have dorsal scapular and long thoracic nerves that will come through the scalene muscles, and then nerves to the levator scapula from the ventral rami of C3, 4, and a little bit of 5. Also, the transverse cervical and suprascapular arteries will come across this triangle as well. The anterior subtriangles, we have the submandibular triangle, which is going to have the floor of the mouth, the mylohyoid, and the hyoglossus muscles in there. There will also be the submandibular salivary glands and several lymph nodes known as the collar nodes. Submental triangle is going to have a floor which is the mylohyoid again, and if this is going to have an unpaired triangle above the hyoid, and then there's going to be located between the anterior bellies of the digastric muscles if you have it putting both sides together. The carotid triangle is going to be important because the carotid will have the common and the internal and external carotid arteries bifurcating at the level of the hyoid. There's going to be an internal jugular vein, the vagus nerve, and also the hypoglossal nerve. The hypoglossal nerve will come around both carotids in the carotid triangle, and then it will go deep to the posterior belly of digastric tendon, heading towards the oral cavity to do the tongue. And in the muscular triangle, we've already talked about the 4 strap muscles in this area and the descending anterior jugular veins that will come through there as well. Let's do another question. A patient with severe asthma has been seen by their family physician, and a diagnosis of thoracic outlet syndrome has been made because of the narrowing of the scalene gap. What's the most likely symptom of this syndrome causing the initial consultation? And if you remember from earlier, there are different types of entrapment in the scalene triangle leading to a thoracic outlet syndrome. And the brachial plexus is often involved in the neurogenic type, and there would be probably upper limb issues that would be the precipitating event getting them to see consultation. If we look at this area, you can see how the scalene muscles are separating off the venous drainage from the upper limb and the arterial and nerve supply to the upper limb. The subclavian vein is anterior to the scalenus anterior muscle, and the subclavian artery as well as the brachial plexus trunks are going to be posterior to the scalenus anterior. Running along the scalenus anterior is the phrenic nerve, which has been removed in this dissection. You can also see the cephalic vein dumping into the subclavian. This is a spot for central line access, which can be made in this omoclavicular triangle using ultrasound or plain anatomical knowledge alone. The lung is very vulnerable near this area because of the cupula that's going to be extending up from the first rib. Now we'll move on to the nerves of the neck. There's the scalene gap with the brachial plexus, and superior to that we're going to have the cervical plexus, and there's going to be one component of that that is motor and another component of that that's sensory. The plexus of the cervical area in general is from C1 to C4, but C1, 2, and 3 make the motor components of the ansa cervicalis, and then the C2, 3, and 4 ventral rami will contribute to the sensory components. Let's take a look at them. We have them numbered where the C1, C2, and C3 will be in red and motor only, and then in blue we have the sensory only. There are 4 things that you want to remember as far as nerves. 3 branches of the cervical sensory branches will come off of C2 and 3, and 3 branches will come off of C3 and 4. First, we have the great auricular, which goes towards the anterior aspect of the ear. The lesser occipital, which will head towards the aspect behind the ear, and then the transverse cervical, which will come across over the platysma to get to the skin, and that's also going to be C2 and 3. Then we've got to have the suprascapular branches, which are coming off of the C3 and 4 components of the sensory contributions, and there will be 3 divisions of that with a lateral, intermediate, and a medial component. The cervical plexus can oftentimes be damaged at the mid-belly of the sternocleidomastoid as it distributes into the neck. Here you can see some of the associated nerves. For instance, C1 will associate with the hypoglossal nerve, so injuries of the hypoglossal can also affect the ansa cervicalis of the cervical plexus. There will also be spinal accessory components that will be coming up and then down through the jugular foramen to get into this sternocleidomastoid, as well as phrenic contributions from C3, C4, and C5, which will be running along the scalenus anterior and can oftentimes be related in some of the damages of C3-4 at least. There will be a superior root and an inferior root of the ansa cervicalis, and remember that this is the motor component, so it supplies the strap muscles and will be composed of C1, 2, and 3. Looking at the vasculature of the neck, we have the subclavian, and we've talked about the various components of it, but now we can look at the thyrocervical trunk, which will oftentimes give off a transverse cervical, and sometimes it will give off a suprascapular, but this may come independently off of the subclavian artery. We have an ascending branch of the cervical portion and the inferior thyroid, which is hooked by the recurrent laryngeal. Also, there's going to be a vertebral heading up posteriorly and an internal thoracic that's heading down along the thoracic cage. That internal thoracic is one of the main transfer vessels for a cabbage as well, because only one end of it needs to cut free and then be reconnected to the heart. If we look at the branches of the carotid sheath, the carotid is going to start as a common carotid, and then at the level of the hyoid it will bifurcate. The external carotid will have the branches coming off of it, which there'll be 8 of, and I use the memory tool. Some aggressive lovers find odd positions more stimulating, and those are in order coming off from the bottom to top. Here you can see what they represent: the superior thyroid, the lingual, the facial artery, then we get to the occipital artery, the posterior auricular artery, the maxillary artery, which is a very variable artery, and then finally the superficial temporal. There may be a transverse facial coming off, as there is in this drawing as well. The facial and lingual vessels may come off on a common trunk. The occipital and posterior auricular will be split by the posterior belly of digastric. The maxillary will be going into the infratemporal fossa, and the superficial temporal will be coming superficially along the lateral sides of the head. The superior thyroid vessel will come down to the superior pole of the thyroid gland. As far as some of the problems with the carotid vessels, there can be a carotid sinus and body that gets occluded, and pressure from the atherosclerotic plaque that can build up in that area. The carotid sinus is going to be the dilation associated with the functions of baroreception for arterial blood pressure, whereas the carotid body is going to be responsible for the chemoreception for blood gas qualities and quantities, those partial pressures, and those are going to reflexively start influencing heart rate and respiration rate. With atherosclerosis, there can be a partial occlusion in the internal carotid or the common carotid, especially near the bifurcation point. This can reduce flow through the middle cerebral artery, and with that you can get transient ischemic attacks. This can cause hemianopsia, or one-sided blindness, because the central artery, which will get into the retina, would be occluded by this as well. They will do an endarterectomy for this to clean out the clots from the internal carotid, and then they can be removed. This has some inherent dangers, of course, as small pieces of the clot will actually blow off and could cause a stroke. So oftentimes upstream, when they're removing these, they will put a basket to collect anything that breaks loose during surgery. Even with the occlusion, there are some connections and anastomoses of the internal carotid and the external carotid that will allow, even temporarily or sometimes for long terms, for the carotid to be ligated. In red, you can see all the branches of the external carotid branches, including the superficial temporal. There's the transverse facial, and the facial itself coming up to become the angular. Then there's the infraorbital branch coming out under the cheek. These are going to anastomose with branches of the internal carotid that come from the orbit region with the supraorbital and supratrochlear arteries that will supply some of the forehead. And here you can see an internal carotid that's been totally occluded and how this would come retrograde back through the orbit and the base of the skull with the pterygoid plexus of arteries, and that could refill the carotid sinus as well, and there may not be any deleterious effects from ligating off a carotid vessel. Here you can see that there's enough collateral circulation that will occur towards the midline and the external carotid branch that it won't be necessary to have both functioning fully. This concludes section 39. In our next section, we'll start looking at the autonomics of the head and neck.